also like to just start with a land acknowledgement that I'd like to acknowledge that the Center for Gender and Sexual Health Equity is situated on the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh people. I also acknowledge that today we're fortunate to have folks joining us from many places near and far, and would like to acknowledge the traditional owners and caretakers of those lands. As myself, as a settler, I'm extremely grateful for the opportunity to live and do our work on these lands, and it's absolutely something we don't take for granted, and just wanted to really honor and recognize that. So delighted today to introduce Dr. Stefan Baral, who is a physician epidemiologist and an associate professor in the Department of Epidemiology at the Johns Hopkins School of Public Health. Dr. Burrell provides clinical care in homeless shelters in Toronto through the Inner City Health Associates. And through his role as the director of the Key Populations Program, Dr. Burrell has led HIV epidemiology and implementation research focused on characterizing the epidemiology of HIV and effective prevention, treatment, and care approaches for gay men and other men who have sex with men, transgender women, and female sex workers across Western and Central and South Africa. And it's this capacity, Dr. Burrell's work in HIV, that we've had a close collaboration with myself and other folks at the center. With the arrival of COVID-19 in Toronto, Dr. Burrell co-led the establishment of the first recovery and isolation site for homeless people in Toronto and has been providing in-person care throughout and shelter. And he has published more than 10 COVID-19 related papers as a member of research teams focused on characterizing heterogeneity in individual, network, and structural risks and strategies to address these. So without further ado, Dr. Burrell, thank you so much for joining us today, and the floor is yours.
Great, thanks very much. So I'm going to start. This will stop other people sharing screens. I assume that's okay. Yeah, I mean, it's such a pleasure to be here and to be joining everybody. It'd be nicer if we were all together, but here we are. So indeed, as Sharon noted, I'm going to talk today, really representing a number of different research teams across sort of like my U.S. hat and then also my Canada hat. And I really want to focus on this sort of question around equity and equity within COVID-19. And so just in terms of disclosures, I'm an investigator on a CHR-funded COVID-19 grant, but I take no personal salary from that and have done nothing else related to anything for money within COVID-19. In terms of an outline today, I'm just going to start very briefly about like heterogeneity and risk for infectious diseases, because I think actually what we're seeing with COVID-19 is not unique to COVID-19, and in fact, it probably is representative of why many of us who work within HIV have started working within COVID-19, because there's so many shared dynamics of inequities across the two, and as well as it relates to STIs. I'll then talk about the epidemiological data that I have, first starting out again in some of the early studies we did in the United States and then moving into Canada, or the work in Canada. And then I want to talk a little bit about like the role for equity within COVID-19 intervention development, and also some more recent modeling led by Sharmista Mishra, who's the PI of that CIHR-funded grant, about how impactful that work could really be in terms of the intersection between equity and impact. So I think, I'll just start by saying that, heterogeneity and transmission risk for infectious diseases is a fundamental principle of infectious diseases. And, there's no infectious disease that I can think of that affects people equally. And many of us who work in different spaces, whether it be tuberculosis, malaria, HIV, the risks sometimes differ, although they're more similar than they are different at times. But nonetheless, the idea of heterogeneity is so fundamental, and I think has often been missing from the conversation within COVID-19. And I think, from an equity perspective, we are really interested in addressing the sort of condition, the structural conditions that really causally that cause these outcomes and these disproportionate risks, and to try to do that without amplifying actually risks among those already at risk. Because it is the case that well-meaning interventions can do that we can concentrate epidemics among particular communities that were already at risk, reinforcing those inequities, and ultimately making it harder to really control, to provide epidemic control. And that has been sort of the story of HIV for the last 40 years, and I think is starting to be some of the story related to COVID. So, I think just in terms of like how we think about risks in general as it relates to infectious diseases, we think of it sort of in two main ways. And so one is like, what is your exposure or your acquisition risk? And what is the size of that community? Separately, we think about your onward transmission risks. And so like, what are the number of downstream infections that happen from an initial infection if we don't address that person's vulnerabilities? And then, of course, there's a whole separate element of like severity of infection in any one person. And there's also a structural element in there because there's also just access to services, whether it be in Canada in the context of universal healthcare, we still have people presenting later, people who don't have access to, pharmaceuticals and medical treatment, et cetera, that might disproportionately affect them in terms of worsening outcomes. And that it's all really intertwined. And that when we look at it, we may just see one overall, as I'll present, like one overall sort of incidence rate, but it really is a mix of different things. And so when we look at this RT, which has been, very commonly noted and presented daily or hourly, we're often presented with it as a weighted average or sort of assuming homogeneity of risks across a population, when in fact, it really is a continuum of risks, but one that could at least be distributed across like high, intermediate, and low risk folks. And when we assume that there's not the sort of mixing that happens between those communities, if we assume it's all proportional mixing, we may underestimate, the actual transmission potential, and we may overestimate the benefit of certain non-adaptive or universal interventions. So that was like the very briefest overview of infectious diseases, but I'm sure a lot of folks here are very familiar, and there's a lot of great reading to do in that space. But I just want to highlight it as sort of what our framing point was. So when COVID-19 first started, we were working with our colleagues at AMFAR, the Foundation for AIDS Research, and they were really interested in a story about inequities as well. And so they started working. At that time, there wasn't individual level race data. This is in March. There wasn't individual level race data in the United States. And so we started working with county level data in terms of what counties were disproportionately African-American, i.e. over the population average of the United States, and then comparing it to all our other counties. And you could immediately see, visualizing that you were seeing in the places where they were disproportionately Black counties, you were seeing higher burdens of COVID-19 cases already. And this was happening within just a few weeks of the epidemic, sort of starting in earnest, or at least our understanding of it. We didn't see it in that time frame, the same differences in mortality, but I will note that when we updated these were analyses in April. Even as of May, those differences in terms of differential mortality started appearing and have been a really consistent story throughout. They're just, at that time, obviously, it was tragically, there hadn't been enough mortality to see it, although it was trending that way. And while we were looking there, I mean, in the earlier analysis, we were really sort of dichotomizing in terms of whether a county was disproportionately African-American compared to the U.S. average versus not. Actually, you saw a somewhat linear curve in terms of the more likely that the county was to be African-American and the overall COVID cases. And so, again, these were analyses just a few weeks in. These particular numbers are from Georgia, but you could just really see, this real. Sorry, these are United States data, but the highest burden county was in Georgia, and you could already see these dynamics happening. But I think what we also found interesting were basically the attributable fractions of those differences. So we wanted to try to understand, what are the drivers of these disparities between predominantly white counties and predominantly African-American counties? And notably, unemployment was already protective. So counties that had higher levels of unemployment, and we really assumed, and I think continue to assume, that if people are not out working, that their acquisition risks are lower, somewhat independent of their otherwise their living context. We did see percent uninsured being significant across settings. And so, again, less of an issue in Canada, but a fundamental one in the United States in terms of access to the health system and whether you're even engaging in testing and ultimately, presenting late. But the thing that came out the strongest, and I think you'll continue to see as a trend in what I'll talk about today, is in the counties where people were more likely to have more than one person per room, or you could say the other way, not have one room per person per household. And in those settings, you could already see that this explained away, in and of itself, a significant amount of the disparities between African American and white counties already as of April. When we started seeing these disparities getting worse, we were as noted, we updated these analyses in July when, as many of you will remember, there was sort of a reopening of many of these states in May. And when you saw that, you could see that actually throughout April, if you just look at the southern states as well as the western states, you saw kind of steady burdens. You had seen these initial disparities and you saw steady burdens. But it was really as you then, the states reopened, that you saw more diverse counties really starting to take off, and primarily whiter counties really remaining pretty steady. And that happening across the southern states as well as the western states. And in California in particular, we had a separate analysis that was really just focused on Latinx or Latino counties. And you could see very clearly within California, this differential happening between counties that are predominantly Latinx versus those are predominant or not, all other counties. And that you were just seeing two completely different trajectories that have continued worsening over time. So AmFAR continued with this work and updated their analysis, and they really found this amazing differential that I think is such a striking figure. These are data now updated as of October, and you can just see this incredible relationship that dates back to really redlining. That, that the residential segregation that has really defined the United States in terms of where people live and how they can live, going back to the 30s and 40s, has really defined where COVID cases have been. And that the least amounts of COVID cases, under 150,000 cases, have been diagnosed within counties that are more than or about 94% white, compared to 4 million cases at that time, diagnoses in counties that were less than 60% white. And so you just see these historical dynamics that obviously predate COVID and have been in place for decades, now really defining the risks that people are at. And I will note that a similar dynamic exists with HIV, and I won't talk so much about it today, but this is part of this interest of how structural racism has really co-affected these two epidemics, and people are really thinking of them as syndemics at this point. Another thing to note is that, while I've talked a fair bit about HIV, that this is also not new in terms of respiratory illnesses. So, when you looked at H1N1, the head of biostatistics, Dr. Bibbins Domingo, wrote a piece back in April that was really prescient, saying, let's not have this happen again, because in fact, during H1N1, the same dynamics were had in terms of much higher burdens among African American counties, among Hispanic or Latino counties, as compared to predominantly white counties. And that those disparities, importantly, actually got worse after vaccination became available. And so it's a separate conversation, but I think relevant as we're now in the face of vaccination across the United States and soon in Canada, or in its early days in Canada, about ensuring that we don't worsen those existing disparities as vaccination rolls out. So moving over, I've talked a fair bit about the United States. I want to say that while I think inequities are extreme in the United States, they are not unique to the United States. And so here are data recently published in The Lancet, although been up as a preprint for a while, from Stockholm. And so this is residential context of mortality for those, I should say it says less than 70, but it's in fact over 70 years of age in Stockholm. And I think what we'll see here is in our first one, I don't have a good way of annotating, and this is when we missed the old laser pointers, but maybe, can folks see this? Shira, can you see my mouse?
Yes, we can see it.
Okay, great. Yeah, so I think what you can see here is in blue is COVID-19 related mortality, and red is basically all other causes of death. And you see this relationship between, this is square meters, but basically square feet per person per household, that if you have less space in a household, you have overall mortality differences and increases, and that there's basically a dose-response relationship to the point when the more space you have is really the baseline for this. And while that's not COVID-19 specific, you'll note that it's not better, that it really is consistent with background. I think the things that also were notable here were multi-generational households that we'll start seeing that if somebody over 70 lived with a working age person, it doesn't affect all other causes of mortality, but it really elevated your risk for COVID-19 mortality. And so you start getting this idea that multi-generational households, which I think we now well understand, really predispose people to risk because there's one person who's out there working and just each day is really new acquisition risk for those over 70. And then, of course, community level risks, that the higher incidence within that community of Stockholm, within the sort of neighborhood of Stockholm, really increased risks. But it wasn't really dose response. It was really like if there's COVID in the community, you know, those folks were really at high risk. And it was to some extent independent of the incidence within that community. It's just basically if there's transmission within the county, it was already going to put people at great risk. And I think what you do see, again, in a bit of a dose-response relationship is the density of people within these neighborhoods. That while that doesn't affect all-cause mortality, it absolutely affected COVID-19 mortality, that the greater the density in a particular neighborhood in Stockholm was potentiating risks. And a separate analysis, now I realize, great. A separate analysis really focused in Stockholm, published in Nature, looked at social determinants of health. And here you can see basically folks that are in their working ages, basically 20 to 65, and those that are retirement, 66 and above. And what I thought was so interesting and so important to look at here is that we know there's some, a healthy immigrant effect, that people who immigrate to our countries are in general healthier than those folks who grew up here, and that you can see in these orange circles all-cause mortality actually overall being lower in these communities. But what you can see is folks from low middle-income countries or folks from the Middle East, North Africa were at really significant risk of COVID that took away any of the healthy sort of immigrant effect and really put them at increased risk. And the same thing was seen for those over 66. So I just want to highlight, you're starting to see these trends of space per person per household, multi-generational households really now being consistent across the United States and Sweden. So we as well started looking at this in Ontario. And in our initial analysis, what I'll talk about now are data for March 1st up to June 20th, using what's called OLIS, which is the Ontario Laboratory Information System, as well as ICS data, which is basically, I think maybe similar to the BC CDC, but in some ways, but is a holder of all administrative data within the province. So together, there was about 88% of lab-confirmed cases in the province. So it was it excluded residents of long-term care homes because we really wanted to understand what were the dynamics in the community. And we were able to do this down to what's called the DA, or the dissemination area, so to about 400 to 700 residents within Ontario. And our focus here, although we had a series of individual level determinants, was really about understanding the social determinants of health. In terms of occupation, are you part of what's called an essential service, although that varies to some extent between places, levels of education and household income, and then also dynamics within your home in terms of the numbers of people in your household, and as we noted, sort of square footage as a marker of square footage per household. And then we looked at ethnicity and race as a proxy for sort of unmeasured confounding or measured confounding in these data sets. And so I'll just kind of get to the point. If you look here at the, I'm going to go back to this mouse. Here are just unadjusted odds ratio. If you go down to visible minority, you can see the same sort of dose-response relationship, that the more likely this area, the A levels, were to have more visible minorities, were having a lot higher COVID-19. The same was true for lower educational attainment, and then numbers of people within the dwelling, so really a marker, again, of space per person in a household. But I think what's really important is that once we adjusted for these analyses, any of the racial disparities went away. And I think that's a really important point, because we've increasingly heard dynamics around, like, is there a biological determinant? Is there something else going on. And I think it's so important, at least within the Ontario context, that these numbers went to zero in terms of racial disparities. But what holds are lower educational attainment, which we think is basically a marker of one's job and one's exposure, as we'll soon see, where we got better data around that. As well, we looked at the number of people in dwelling. And I think, when we looked at this, often the number of people in a dwelling held true because it's sort of the end result of a lot of other dynamics. But those were really the only things that held significant across this sample of, all of Ontario. And I think at that point, something like 750,000 COVID tests. So, a very, I think, a robust data set. And this says in preparation, but in fact, it's under review and has been a preprint for a while, which I'll include as a link soon. So when we zoom in on Toronto, so that was Ontario, we've started using Lorenz curves as a marker of inequities. And I think, even just sort of eyeballing, you can see there are obviously parts of the city that have been really affected by COVID and other parts where there are basically no cases. And what we could see just from the Lorenz curve is that about a quarter of the population account for more than half of the cases. And so we've really wanted to sort of dig in on like what are driving those disparities and are they improving? Another dynamic I want to make the point of is the epidemiologic transition that happened in Toronto. So actually, the Lorenz curve that I just showed was the overall data. But if you separate out from January to March, when these were primarily travel-related cases, you could see, in fact, it was the other way around. That while there are less cases overall, it was really geared towards higher income folks as compared to lower income folks. And it has really been that when May onward, when we transitioned from primarily travel-related cases to primarily local transmission, that you saw it go the other way, which is really that more cases were being borne by lower income communities as compared to higher income communities. And then, those are all community cases. I think is obvious, and I think we understand that, like, the vast majority of cases have really been within facilities, so including the types of facilities I work within, in shelters. And so here you can see, if we were just to use a normal curve as we're doing here, where we can actually show the types of cases in the community in blue, the cases within shelters as well as those cases in purple and the cases within long-term care facilities leave the graph so quickly so as to not be helpful. But it's really when you see the cases in shelters that people were 20 more times more likely, even up until May, to be diagnosed within a shelter and over 60 times more likely to be diagnosed within a long-term care facility. So I think, again, understanding that, there's been a tremendous amount of facility-based transmission, but that those transmissions, like the staff of those facilities, are not independent. They don't live at those facilities. They live in communities. And so what we wanted to look at was basically where are workers of I should say all healthcare workers working? And I'll note that when we looked at this overall in terms of all healthcare workers, we didn't really see much of a relationship in terms of a Lorenz curve, in terms of a disparity. So we separated out in terms of long-term care facility workers, as well as, and then non-long-term care facility healthcare workers. And what you can see is that there is absolutely a disparity that in the communities where more long-term care facility workers are likely to be working are bearing a higher burden of COVID as compared to the line of equality. And really that doesn't apply to doctors and nurses and others, that it really is more of the line of equality. And what we could see there is that about half of the cases amongst the staff were among staff living in the worst hit areas. And so, you're already seeing this sort of heterogeneity between where the staff are living and the communities that are being affected. And that applied by income disparity. And so we saw that, about half the cases were in the most materially deprived areas, as well as these dynamics around structural racism, where we saw about 40% of the cases were in the top 25% most ethnically concentrated areas. As we've talked about, is just really a marker of living and working conditions. But nonetheless, sort of that dynamic between potentially occupational acquisition risks and community-level transmission dynamics. So I'm going to move on to talking a little bit about public health intervention development, and I always think people should take a look back to our SARS-1 report. It's available on the web, and it was prescient. I think many of us will remember that it was after that we formed PHAC, and in Ontario we had the Ontario Agency for Health Protection and Promotion, which became Public Health Ontario. But it is amazing that when you look through this report, which is not too long as far as government reports go, it really laid out a lot of things that I think we should still be paying attention to, and laid out ideas about intervention development, including in public health emergencies of international concerns, or FEICs. And I think some of the principles that I think we hold near and dear to our hearts within Canada, and I think beyond, is equity, which is just to say that public health should aim to do more for those who need more. Social justice, where we want individual folks, and especially communities, to have a balance between the intervention benefit and burden. And also participation, where we really want to engage communities in the decisions that are going to affect them. And I think another piece to introduce here, at least is in terms of how I contextualize effectiveness, is the equity effectiveness loop, which was put forward by Peter Tugwell, a Canadian, maybe known to many Canadians as a policy guru or health policy guru. But really says that, if you look at sort of the first piece there, if there are socioeconomic disparities in terms of the etiology or the burden of illness, that we want to say that an intervention should actually improve those disparities and not worsen them. And we want to think about what are our options economically to improve socioeconomics, and then we want to translate those into programs, and we want to keep doing that. That we want to ensure that the burden of illness is going down, but that disparities are decreasing as well, as a marker of success of our intervention. So it's really within that frame that I'll present what has happened. First, I'll go back to the United States. We saw this very early, that who was being decided as essential workers was deciding risks. And so, we saw that Latinx migrants were more likely to be working in meatpacking plants. President Trump decided that meatpacking plants were essential workers and would not, would not be given paid leave, would not be taken out of their work. And that has been, associated with a tremendous amount of transmission and tremendous amount of burden within those communities. We could also start seeing, in terms of even where, and again, United States data, but where we were seeing COVID-19 testing set up. So, for example, in Philadelphia, famously, poor neighborhoods, as I've tried to make the case for, and hopefully you've accepted, were far more burdened, but all the testing was set up in higher income neighborhoods, and transit systems are really challenging, and often relying on cars that people don't have in order to wait in lines. And in fact, many of you will have seen those famous photos of cars waiting for COVID testing, which really are not well set up for folks that are, don't have cars, for example. Another dynamic was just in terms of even how lockdowns work. This was, I thought, really interesting analysis pretty early, where they looked at mobility by income level. And I'll note many of us are doing similar analyses across Canada. But what you could see is that if we just focus on the completely at home one, the yellow are the highest income folks. And you can see actually they're most likely, pre-COVID to be out, and they're they're the least likely to be home. And so you can see this, that they sort of hit this mark of being more out. And then what you can see, interestingly, is that transition that happens, that when the sort of lockdowns happen, it just is an incredible increase in their likelihood of staying home, to the point when they are the most likely to be at home, and folks within the lowest income quintiles. And then it really is a true dose response after that, that those in the lowest income are least likely to be home because they're most likely to be essential workers and out. So I'll just note that I thought that was, provided some insight, again, non-Canadian data. So then let's look at home. Here I'm presenting data up until November 27th. And this is presented at the science table, so it can be presented here. But what you can see is those inequities. This is now by visible minority status, and in red you see the most highest visible minority, and in blue you see the least visible minority. And what you can see in that early wave in April and May were those disparities that we presented earlier, that, you know, where housing and dwelling adjusted for. But then you saw all of that decrease, you know, throughout the summer as we knew, and starting to increase into September, at which point, you know, these additional restrictions were put in place. And I think since then, what you can see are that it is now a tale of very different stories depending on different communities in, you know, in Ontario. And in blue, these are the least visible minority, and obviously you can see increases, but it's actually been pretty steady. And it really has been in the communities that are the highest visible minority where there have been extreme increases in burdens. So, you know, so we want to try to understand those dynamics. So also note we saw similar dynamics in terms of recent immigration, although, you know, not as strong, but you can still see the sort of K recovery model where it really, you're telling different stories depending on what communities you live in, so by recent immigration. You can also see the dynamics in terms of income level. And I think, you know, starting to get insight into what's starting to happen by income level, but it really is then the key markers here, which is who are the folks in terms of the low suitability of housing. And what you can see here is that if you have suitable households, which really represents a large number of households, 97% of households have suitable housing, but it is in the places where you have where you don't have at least one room per person per household, where these inequities have been extreme and the increases in burdens have been extreme. And then in multi-generational households, a very similar dynamic that you can see differences by multi-generational households, with the most likely to be in multi-generational households during these shelter-in-place and lockdown mandates to be the most affected. And then finally, I think the dynamic that I think many of us expected, but just to see it so visibly, is where folks are most likely to be essential services. And, you know, essential services these days includes DoorDash and Amazon and restaurant takeout and, you know, a whole series of bakeries and internet and the things that often are keeping many of us that are working from home very comfortable. These are folks that are out there, and it is absolutely represented in the burden of COVID, that in where folks are the least likely to be essential services, again, the burden has been pretty steady. Obviously, it's increased in this wave, but it's been pretty steady. But it has really been, at least in Ontario, extremely affecting those that are more likely to be in essential services. So we want to try to model this. And so we want to talk, this is sort of the last phase of the talk, which is to say that, you know, as of now, the model of intervention has generally been a one-size-fits-all model. But the burden is not equally distributed. And so we want to start asking the question, what could we get if we actually took an equitable approach to our intervention approaches? And I'll note that this came about because often people were saying, well, don't let equity get in the way of saving lives. And I think, you know, what we've tried to empirically assess is actually whether equity will help you save lives. And taking a more equitable approach, as Dr. Tugwell and others talked about 15 years ago, actually is associated with greater impact as compared to, you know, just getting in the way of impact, let's say. So there's a series of different projects. I'll note Sharmistha Mishra is really at the heart of many of these, and many of you may already know her. But there's a few different studies, including work going on in Quebec, work going on within long-term care facilities, the New Covenant study led by Stephen Wang, and then work, newly funded work led by Sharon Strauss within long-term care homes called IPAC Plus. And what it wanted to do was try to model out understanding that there are high-risk communities, which represent 25% of the population about, and then there's sort of relatively low risk. And I'll note, even this is artificial because it really is a continuum of risks, but just from a modeling and visualization perspective, want to just really present what this looks like. We used, just two strata, and the pre-pandemic contact rates were actually pretty similar, using data about 12.5 contacts per day across settings. And we've used our own data from Ontario then to sort of populate what these disproportionate risks look like. So then from an interventional perspective, you know, even just like an equitable approach would say that we could reduce transmission by 25% across all neighborhoods. So in red here, you would see that if we were able to decrease transmission risk by 25% in all networks, the networks that are higher risks, you would see significant decline. And as you would, although in blue, these are generally higher income neighborhoods, you would still see significant benefits if you were able to reduce their transmission risks by 25%. Now, here what is closer to actually what's happening and why these inequities are getting worse, which is to say that our sort of lockdown shelter-in-place mandates are reducing transmission risks by about 10% in high-risk networks and about 25% in lower-risk networks. And so, we are seeing that in reality, in our base case, which is what we're experiencing as we speak, you see these higher burdens in red here. And this would be better with the laser pointer, but we'll just kind of have to work with it. But that when you reduce transmission by about 10%, you see a reduction, but obviously not the reduction that you would have had with 25%. And importantly, you don't also get the same level of impact because there's some spillover even in the higher income neighborhoods. That if you don't serve lower income and more at-risk communities, it also does affect the rich folks and richer folks, working from home. And that there is some additional transmission within those communities, but obviously not to the same extent. So then, I just sort of want to talk through a little bit about what it means to be doing our interventions. And I know it's a busy slide, but I'll just say, here right now is our base case if we move to the left of the slide. Our base case, which is what's happening now using these two models of the 25% of the communities versus 75%. We have a cumulative incidence rate ratio of about 2, and our interventions are basically worse. The inequities are getting worse over time. That the most recent data that we've had, at least from Ontario, is that these inequities are worsening pretty significantly so. If we move to the middle model, we have equal reach, which is again that model that everybody's able to reduce their contact rates by about 25%. And you can see significant reductions in overall transmission. In addition to, you can see the inequities getting better in terms of less inequities across those areas. But then I'll take the last one is really what is happening right now, which is that the high-risk networks are only able to reduce their contact rates by about 10%. All other, the low-risk areas are able to reduce their contact rates by 25%. And overall, while there are reductions, you can actually see inequities getting worse, significantly so over time, which I think is pretty reflective of what's happening. So then, the last data slide that I'll present today is what is it that we're missing? What is it that we could get if we actually considered equity as fundamental to our intervention strategies rather than as an afterthought? And so these are now data from the entire population, all networks, all neighborhoods. In gray is our base case. What we can see here, and in our pink dashed line, we can see where we are doing sort of what we're doing right now, which is that we're reducing 25% in our low-risk areas by only about 10% in our high-risk neighborhoods. In gray is what we'd sort of consider that prevention gap to be, was to say that if we were to able to add resources, which we know we can do in terms of pretty basic stuff and housing supports and paid leave and other dynamics that can protect folks and present them additional opportunities for safety within higher risk areas, we are missing an overall benefit in terms of transmission. If we were even to take a greater sort of equity lens to our work and say, that we're actually going to really focus our efforts on particularly burdened communities. So in orange dashed lines, we would say that, we are really focused on investing in marginalized communities, at-risk communities, to reduce those transmission risks and actually spend less and invest less in high-risk folks that, or I should say low-risk folks, higher-income folks that are already relatively protected. That's really where we get our biggest bang for the buck in these transmission models. And I'll note that there's sort of a similar, we're playing with different like sensitivity in terms of how much it is that we would get. by, sort of 10 versus 25% and 55 and 62%. But I just want to make that overall point, maybe even not focus between the orange and the maroon lines, is to say that a truly equitable approach would really invest disproportionately in the areas most affected with the resources that they need in order to protect themselves and their communities and their families. And that's really, a pathway to achieving the greatest impact. So just to say a few things, and then hopefully there'll be some interest in discussion. I think, the early modeling for COVID-19 in Canada just assumed homogeneity. It assumed that, I think Mohammed on the line, we're all in this boat together and everybody's at the same risk. And I think it was probably pretty clear, whether you're in Toronto or Vancouver or Stockholm or South Africa for that matter, that is just not the case. That, as I think famously said, we're not in this boat together. And, we then wanted to sort of say that, in fact, the COVID-19 epidemic in Canada is marked by, heterogeneity and risks, and that, there are different folks over time and in different settings that have been at greater risk. And we really haven't done a lot about that to date. And I think there is, at this point now, 10 months into this, that, we can leverage these data on heterogeneity and these different risks to do better on equity. And is to say that actually that requires a lot of work. I will note work, I think that's been ongoing more so in BC than in Ontario. So, it's great to be talking to you folks. But it's not to say that it's cheaper to do those things. In fact, it takes more effort and more time to have your data systems and serve communities. But it really, I think, represents a path to be, consistent with what I think many of us as Canadians think we hold true about our societies, which is about affirming human rights and wanting equity within our healthcare systems and our social systems for that matter. So just to thank a number of folks, Sharmista Mishra and Jeff Kwong, who are Sharmista really is the PI and a few and co-PIs, Jeff Kwong, a whole series of great analyses. The preprint was led by Maria Sundaram, who's here as a postdoctoral fellow with Jeff. Greg Millett and Carlos Rodriguez-Diaz are investigators in the United States who I did the work in the US with. And then to thank CHR and the St. Mike's Foundations that supported the earlier work, and obviously St. Mike's and Li Ka-shing and ICS. So thanks.
Thank you so much, Dr. Burrell. That was a really, really fascinating talk, and I'm sure folks will have some interesting questions. So the first question we have here is, says, very interesting data for those doing health equity and social determinants of health research. Sorry, just a minute. None of these findings are surprising around the disparities. How much more data do we need to actually make policymakers and others do something about inequities? I feel like we haven't moved forward much from the start days. What's the actual next step?
Yeah, it's interesting. I think that in, obviously I'm not going to speak for BC, so I think that there's a different, in speaking to some of the folks there, I think there's a different framing, but I'll just speak about Ontario. I think in Ontario, I think that there has been a dynamic where I think there's been acceptance of these inequities, but this sort of feeling like the only way we can protect communities is to decrease overall community transmission. And I think that's a bit of a false dichotomy. I think COVID has been marked by false dichotomies, but that's one of them, is that we can't invest in particular communities and support particular communities to try to address risks and burdens within that community. And we're starting to see really exciting initiatives happening, led by the communities themselves, the South Asian Task Force, for example. There's great work with Indigenous communities led by Janet Smiley and others. So I think this work is starting, but in terms of investment, it's absolutely not been there. And I think the message is always there's no money for that. And you feel like, we're starting now to do these cost effectiveness analyses and costing analyses because it would be far more efficient to really invest in very clear structural interventions like, scaling up the housing supports, scaling up outreach testing and testing in particularly burdened communities, managing outbreaks as they're happening, and then just paid leave, which I think is the case for many, but is not the case yet for many others, like agency hires and contract hires. And so we continue to see outbreaks, but I think we also have to think about like that we can understand dynamics of where that's happening. Nathan Stahl recently presented data that even in the context of staff cohorting within long-term care facilities in Ontario, they still saw a ton of mobility between places because it didn't apply to the agency hires. It didn't apply to the contract hires, which is a significant proportion. We've had the same dynamic within the shelter setting. So I think we really have to get very real about our systems. I'll also note our workers' comp, WSIB here in Ontario, I don't get in trouble for saying this, but the way that they're making their decision-making about who gets paid leave and who doesn't, is like a value judgment. And it feels like a lot of the arguments that we often have about PrEP, which is like, well, who deserves like pre-exposure prophylaxis for HIV? And the answer is anybody who needs it. And I think, here we've had this, well, what was your contact? Oh, you were out for dinner? Okay, well, no paid leave for you. And I think we sort of have to think about like how we're making decisions in terms of whether it be from a perspective of like judgment or really just be a perspective of addressing people's unmet needs that is continuing and feeding transmission. And so I think it's multifactorial, but I'll just note that in this response, we've designed a response that's best for rich people, and it feels like it's only getting worse. And I think we just have to reflect on that as a people and then just call for it to change, because I think many of us are probably pretty aligned here. I don't think it represents the majority of people. I think most people still feel COVID transmission is related to personal choices, social gatherings, all these things. And I think all of the data tell us that is part of the story, as always. Like, it's a little piece of the story. A greater piece of the story is the stuff that's harder to talk about, which is that we have grave structural racism in our systems, and we have grave inequities in our systems that are driving certain communities to continue to be at higher risk. And again, in the context of shelter in place and lockdown type mandates, these are getting worse. We continue to say, well, we'll get to the equity piece, and we just haven't. And so I don't have a great answer other than I think it just seems to not be a big part of the story yet, which I think is shocking to us when we're actually looking at these data.
Thanks so much. That's a great response. And it links to the next question, which is just, we'd love to hear a little bit more about any experiences you've had or seen in engaging with policymakers on this. What do we need to ensure public health is driven by the equity lens you've described?
I mean, so what I'll say is I think in the last few weeks, so we wrote this a commentary, back in June, and we thought it was very controversial talking about these things, and we got, went into CMAG, and we were excited about it, and it just but no media, Sharmista was the contact, no media contacted her, nobody was that interested in it, and so I think part of that, again, is part of some self-reflection in the sense that I think people just didn't want to hear it. But I do think that more recently, as the data just continue to be clearer and just so pervasive that you just can't avoid it. It's true in Calgary's seen this recently. I know it's the case in Vancouver. Everywhere in Winnipeg and other places, it's the only universal defining characteristic. So to that end, in the science table recently, Dr. Brown presented this equity work as part of it. Toronto now has a COVID equity plan that I saw one of our counselors, Joe Cressy, talk about. And so I think that it's starting to kind of get integrated into the dialogue and the narrative, and hopefully that will mean some money will flow into better serving communities. So I think it's happening, but it's just amazing that it's December, and we just that we're still having these conversations. I think is tough to come to terms with.
Absolutely. Okay, the next question is, your excellent presentation has underscored that COVID has illuminated underlying inequities. You've made a strong case that reducing inequities should have a significant impact on COVID burden. What specific resources are you thinking about mobilizing to achieve reductions in inequities?
I mean, so I think it's such an important question, is that, each of these data, when we look at I think some of these dynamics are old and ingrained into our societies, and there's inequity in every society. So I think that that's an important thing. Now, some of it is just to reflect on how we've set up society. That, I agree, is not a short term. There's a longer term dynamic that I think we should not when this crisis is over and vaccination happens and all these things. We should not forget about that, although I think many of us worry we will. I think in the short term, there are some absolutely clear and actionable dynamics where like simple questions to ask in the context of long-term care facility outbreaks. Is everybody in that facility, for example, getting paid leave? Just a very simple question. Is everybody in that facility, do they have access to paid leave? Does everybody have access to easy testing? Shift workers, contract hires, agency hires, have we presented a testing system that works for them? Or is it a lot of still facility-based testing that they don't get time off, they can't like take a call while they're waiting in line, and we've just not set it up in a way that works for those communities. So just that sort of outreach testing and support and getting rid of any of the barriers to testing, again, with people being concerned. Right now that the federal benefit is $450 after taxes a week for a maximum of 2 weeks, and so $900 does not take care of a household. And I think we should think really hard about what are the pressures that people have continuing to work in those settings. I will note personally, we're dealing with an outbreak in the shelter in which I work, but I just want to say, like, the folks who are at risk, and again, not with blaming them, but it's like some are the folks that are not getting benefits were the folks that were initially at risk in our setting. And again, I don't blame them. It is a dynamic of multiple jobs and multiple places, and just having a lot of acquisition risk. But what then happens is that residents and people have sadly already died. And so it is this dynamic of like not meeting people's underlying needs will cause lives, in Canadian lives. And then I think there's a really element around space. And I think these isolation sites have started. They're not integrated at all into our system. So it's like the only folks that end up at least in Toronto's site are folks that are like well versed with the internet and like find their way there. We're not like integrating in the isolation sites into the system as a whole. So if you get tested, we know this is a virus that once you become symptomatic, the viral load peaks very quickly and your infectiousness peaks very quickly. And that's what, when we really need to do something for you, not send you home and have you wait 3 or 4 days for your results and potentially infect everybody in your household. So I think there's a number of these things that we can better do, but we also have to ensure that they're not afraid of going to these sites. We don't involve police in any of this because they don't need to be there. There's no role for them. And I think that, but we also create a place where people are willing to go and happy to go and comfortable going to isolate, effectively and protect their families. So I think there are a number of options at this point of things that we could be doing, but they cost money, and we've not been willing as a community. I can't speak for BC. I can only speak for Ontario. Been willing to make those investments for folks.
Well, that leads perfectly into the next question. Thanks, which is about. To the extent that you're familiar with what's going on in BC, can you describe any specific interventions that should be added in BC where we've invested heavily in the downtown east side, including a shelter strategy, infection prevention and control, and universal sick pay?
Yeah, I mean, I think, so thanks, Megan. I think around universal sick pay, I think the question that we often have, and again, I want to highlight that I think I'd be happy, I'm always happy to be living in BC, but like BC is still, I think, the model. So I just put that out there as a public health practitioner. I look to it as a model, and I think a number of the folks that are leading there are leading really effectively, and I think, and I'm really thankful, even as a Canadian, for their leadership. But so I can't speak to the details. I can only say that we often hear also about universal sick pay in Ontario, but again, if in fact it doesn't apply to like a number of workers, so it's really getting into the weeds of like what it means, how much sick pay is, what are the barriers to people getting it, like this sort of implementation questions around ensuring that like this program that exists is actually accessible and is being used effectively. And I think it's in those weeds that we've just sort of like, like in this response, we've often just like made things available and then like been like, people should use them. But I think we've learned, whether it be PrEP or condoms or ART or anything, needle and syringe exchange or any of these things, Insight, for example, like there takes a lot. It's not just making it available and people show. There's a lot of outreach, demand generation, all of those sort of implementation questions that I think we need to do better about now, 9 months in, to improve. And I'll note, I think it relates to Travis's question about vaccination. it's very much the same thing. So I've seen the NACI guidelines. There's some complexities in the NACI guidelines, but I think in writing, there's a lot of things that I really like about it. I think it's going to be like how it rolls out in practice. When I look back on this sort of inequity piece around vaccination for H1N1, the same thing applied in Canada, and obviously it's always worse in the U.S. for inequities, but nonetheless, it also applied in Canada. And I think it's about how these things get translated into not designing things for communities, but designing it with communities, ensuring that community leaders are part of the conversations about how to message and how to communicate and how to deliver to their communities because they know them best. And I always feel like I trained in public health, obviously in Canada, but like I don't know how to serve a community. Like I know how a program works, and I think we need to get back to this model where we really learn from the communities about how to serve them, and then find that sort of sweet spot between like what we know works, which is delivering a vaccine, and how they know how best to deliver it. And I think we forgot that a little bit along the way, not a little bit, I think a lot, at least in some places. And I think we need to get back to that of delivering things with folks, hearing more, listening more to communities in terms of what their unmet needs are, and then designing programs accordingly.
Thank you so much, Dr. Burrell. I think we will end there. I appreciate you answering all the questions today. It's been an amazing talk today. I know people have really enjoyed it, and I think the questions were excellent and just so well answered, and have given us a lot to think about, especially about the process of implementation that you're talking about. 9 months in, we need to get a little more sophisticated. So really appreciate all the insights and compelling data that you've shared with us here today. You referred a few times during your talk to Dr. Sharmista Mishra.
Hey.
Thrilled to actually that our speaker next month. So for those who are interested in continuing this conversation or want to learn more about COVID inequities and mathematical modeling, we would love to have you with next month on January 21st. Dr. Mishra is the Canada Research Chair in Mathematical Modeling and Program Science. And we'll be really thrilled to continue the conversation in the new year after everyone's had a bit of a rest. So thank you so much again, Dr. Burrell, for your time, and to everybody for joining us here today. Wishing you all a restorative holiday and a happy new year, and looking forward to reconnecting in 2021.
Thanks very much for the opportunity.
All right.